Good morning, and thank you again for the invitation to come here. I think this meeting has been absolutely fascinating. So I want to talk about medical surveillance for asbestos-related diseases. And I want mostly to talk about go back to the issue I spoke about the other day, which was lung cancer screening. But I feel the need to introduce with various things, which you frankly probably already know, that there are benefits to medical surveillance. And I think some of them are obvious, but I think the first one maybe is a little bit less obvious, is that people have the right to know what happened to them. They have the right to know if they were exposed, whether they're sick. Even if doctors can't make specific interventions, or even if we don't have specific treatments for their illness, they have the right to know their own health status. And then there's some other benefits which you can see up there. Periodic examination, which I know you perform in various places. I don't need to go over that because it's fairly standard. What's interesting on chest x-ray is how much variation there is in different countries. So I'm not sure exactly what you do, but this is from the Helsinki 2014 asbestos meeting. And if you look, for instance, at the United States, we require a chest x-ray for asbestos-exposed workers, but it's only required for current workers. Of course, that, you know, is kind of a nonsensical policy, because the period of highest risk for asbestosis and all the asbestos-related diseases is most likely after people leave the workforce, right? Because of latency, after they retire. Nonetheless, that is our current law in the US. Other places get it more correctly. For instance, in Japan, they cover past workers exposed, but oddly, they offer chest x-rays twice a year, which frankly is excessive. I think Germany probably has it most correct, which is a chest x-ray every few years, and for some people they actually now require low-dose CT. Now, but I think we can all agree on the utility of medical surveillance and what it should consist of, but I think what's most important is that you find a way to keep exposed groups together, or rather that you find a way to identify and recruit exposed groups for the purposes of medical screening. Because once that mine closes and those factories close, those workers are going to disappear. Some of them are going to move, they'll drift off in various ways, and then you'll have no way of identifying them, and you'll have no way of doing medical screening and education. So my plea really is that you emphasize and find ways to accomplish this. I'm not sure exposure registry is the way to go. It hasn't worked well in other countries, but at least to find a way to keep groups intact so that you can offer screening and education. If you think that the general healthcare system is going to recognize occupational disease, I just want to give you an example from the US. This is a person diagnosed recently with malignant mesothelioma, 2015. His occupational history is he worked as a security guard, so obviously he wasn't exposed to asbestos, but that's the occupational history that the doctor received. But actually, when you talk to him in detail, he worked at a shipyard in Brooklyn, and he also worked with brakes in repairing forklifts. So clearly he had occupational exposure. Even for malignant mesothelioma, his exposure wasn't identified, even for the disease where we know he was exposed. So my point is that if you rely on the healthcare system to do a good job of identifying people exposed to asbestos, I suggest that you maybe rethink that. Other examples, but I don't want to dwell on that. Malignant mesothelioma, a very short statement: we have no method of early detection. There is research on blood biomarkers, but there is nothing successful. So let's talk about low-dose CT for the purposes of early lung cancer detection. In 2010, the National Cancer Institute published the study which showed that a very large study, very expensive, 50,000 people, and it showed low-dose CT could reduce lung cancer mortality. And this was an excellent study, and the first time this really has been shown. This is the group that they included in the study. They were age 55 to 74, and they smoked. And they smoked a lot, a pack a day for up to 30 years, and they quit relatively recently. Now, the reason they picked this group was not to identify the largest population that might benefit from lung cancer screening. They picked this group because they wanted to get an answer to their question. In a very high-risk group, does low-dose CT reduce lung cancer mortality? And when you conduct an epidemiologic study like that, which took $250 million and 10 years, then you want to identify the highest risk group that you can. So the purpose of this study was to use a group to test that hypothesis. It was not to identify the full population who might benefit. And so the study was successful, and then in 2013, our insurance companies and Medicare began to offer low-dose CT for people in this age group and who had these smoking characteristics. So in other words, they just really imitated the NCI study. So you say, where is occupation? Occupation is not included as a risk factor. Now, fortunately, a year later, the National Comprehensive Care Cancer Network, which is all the big cancer centers in the US, and they have many policy statements, treatment recommendations, they looked at this issue and they said, yes, we agree that group should be screened, but we also recommend that a second group be screened, and this group is maybe a little bit younger, may have less smoking history, if they have another risk factor for lung cancer. And what other risk factors for lung cancer are there? Well, it's asbestos and silica, or if they have a family history, or if they have emphysema and the like. So this was their recommendation. There are no real data to support this. And so we conducted a low-dose CT program. I reviewed this the other day. We were publishing these data that I'm going to show. I did not show this on Wednesday, but on 7,000 nuclear weapons workers. And so our eligibility criteria were different from the big NCI study. We would screen people at 80 years old if they were healthy. We took everybody who smoked cigarettes. We included them. If they quit 30 years ago, we included them in screening because they do have an increased risk, even if they quit smoking 30 years ago. And if they worked in the nuclear weapons production industry. So, so this is what we found. The National Cancer Institute, when they did the baseline, the first screen, they found 1% of the people had lung cancer in the low-dose CT group. So 25,000 people, and about 260 people, or 1% of the 25,000, had lung cancer. So that represents the risk of that group as detected on low-dose CT. So we took our study population, and we took the 1,500 workers who met the NLST criteria. Okay, so they had the same age, same smoking. And we found that the yield, the baseline, what we call the screening yield, or the percent with lung cancer at that initial scan was more than 1%. It was 1.5%. So that meant that in the group who was occupationally exposed, if they also meet the age and smoking, they have the same level of risk, or maybe higher than the NLST. So that was interesting, but we expected that. The second group we looked at was the group that met the NCCN criteria number 2. And that is, they were younger, they smoked less, but they had occupational exposure. And the question was, what percentage of them had lung cancer on the initial scan? And we found about 1.4% of that group had lung cancer. That is the same, or maybe higher, but statistically it was the same as the NLST group. So what that meant is you can lower the age to 50, you can reduce the level of cigarette smoking required if they have an occupational exposure, and it can be asbestos or silica or any occupational exposure. And it's one of really the first demonstration that you can use occupation in combination with age and smoking to define a group that will have the same risk and benefit from that the NCI study demonstrated. Now, the NCI has revisited their own study, or the issue, and they've looked at, through modeling various data sets, they looked at whether beyond age and smoking, these other risk factors, including occupation, should be included. And they have decided that it is a better approach to use a broader set of risk factors. And they published this in 2016. No time really to go into it, but in 2018, just recently, they published this, and I quote, "So to better capture high-risk smokers and prevent premature deaths from lung cancer, eligibility for lung cancer screening should be based on reaching a cost-effective risk threshold that balances benefits and harms by using a lung cancer risk tool." And what kind of tools are there? Well, you can go online, and these are from various organizations in the United States, and you can put in age and put in smoking history, and you can put in a history of asbestos exposure, and in some other tools, occupation in general, and you can identify the level of risk, and if it meets the same risk as was seen in the NCI study, then you can justify lung cancer screening. And so lastly, this is my last slide. So we know that we can factor in occupational risk in looking at who should be screened. But that still leaves open the question of which workers, what level of risk among workers. Should textile workers with 5 years of exposure, or construction workers with 10 years of exposure? Same questions with silica. We don't really know the answers to those questions. I think they're secondary questions. The first question is, should we do this among occupational groups? And I think we can say yes. Then we have to get to the questions about who should be included. So this is from a different study among insulators. The insulators, these were the group started by Dr. Selikoff a long time ago. They were heavily exposed, and this group was exposed to asbestos for 30 years. So this is really a heavily exposed group. And if we look at, in the NLST study population, their rate of lung cancer was 58 per 10,000. Just focus on that number, 58. And the question is, among the insulators, who smoked or not, or had asbestosis or not, those subsets, which ones reach this level of risk of the NLST study that we can justify lung cancer screening? Well, the insulators who didn't smoke, and this was a 25-year follow-up study that I did, published a few years ago. Among the insulators who never smoked, their lung cancer death rate was 21. It was a lot less than the NLST threshold. Among the insulators who were non-smokers who had asbestosis, their death rate from lung cancer was higher than the whole group of never smokers, but it's still about half that of the NLST. So that means that it's not easy to justify lung cancer screening among heavily exposed workers to asbestos who never smoked cigarettes. I think there's that's still an open question. This is just one study, and there are details to look at, but I think this is useful information. Actually, when you get to insulators who smoked, who did not have asbestosis, their death rate from lung cancer, 51, is very close to that of the NLST, and clearly they should be included in smoking insulators who do not have asbestosis, should have low-dose CT. And then finally, the group that's worst off, which is the insulators who smoked, who also had asbestosis, had twice the death rate from lung cancer. So this begins to shed some light on who should be screened within the occupational world, although I think a lot of work needs to be done. But in the tradition of Fernanda Gianassi and also Linda Reinstein from my country, I'd like to end on an optimistic note, which is even though we have a lot of work to do is to define what groups really within the occupational world should be screened, we should recognize that for the first time really for non-infectious, an important non-infectious cause of mortality in the occupational, given occupational exposures, we can actually interrupt and cure people from a disease caused by their occupational exposures, and that we need to start doing this. Thank you.